Hi, I'm Jeremy. Maybe you've seen some of my other videos or my posts on the CCI communities, or you've been on my subreddit, which is r/cervical underscore instability. And yeah, if you know, I'm a CCI patient, and I've gotten pretty far at this point, but I'm still not perfect, but doing pretty good. And looking back, I remember the very beginning being bedridden for a long time and wondering like, who do I even talk to? And what do I do about this? It's really scary and confusing. And so I'm trying to go back and interview physicians and try to push for open dialogue between these physicians and patients and try to get more info out for people who are in those early stages, especially. So that's what we did today. I've got another interview with, it's a duo. So it's a Regenix physician that does posterior injections from C0 and below, and she does them in Belgium, and then she partners with an upper cervical chiropractor who does Blair chiropractor, and they kind of have it's an hour-long discussion. They kind of have a methodology that they're working on, kind of like a roadmap of, at what point do you go for more adjustments, and at what point do you need to look at more injections? And these doctors trade scans and symptoms and work with you. They're both located in Belgium, and they kind of do this in tandem, and I think that's really smart. So, anyways, if you wouldn't mind liking and sharing the video, if you're trying to get more info on CCI stuff, hopefully I can get more and more of these going. We've also got a mega thread here that I'll link to in the description, and it's just like a long list of doctors and some DMX places and people that treat CCI, and we're working on it. So, yeah. Anyways, the doctor is Dr. Anita Van Domselaar, and the upper cervical chiropractor is Dr. Geoffroy Van Innis. And I'll put links to their websites too. It's vaninnis.com, and Anita's clinic is called relieveclinic.be. So, as always, not medical advice, and do your own research and keep asking questions to the doctors and the communities and all that stuff. So, enjoy the interview. So we have Dr. Anita and Dr. Geoffroy.
Good enough. Works
All
for
right,
me, man.
cool. So Dr. Anita is you do what type of physician are you again? A pain physician?
Yes, anesthesia.
Anesthesia. Okay, cool.
Yeah.
And you guys are located in Belgium?
Yes,
Cool.
correct.
And Geoffroy, you are an upper cervical chiropractor. What type is that? Nuka, AO, or Blair, or something else?
Blair. I'm specialized in Blair.
Okay.
Yeah.
Cool. And you guys partner together. So you do upper cervical injections to try to regenerate that C0, C2, and other areas in the cervical spine and across the body. But you do that, which is pretty unique. The C0, C2, the sensitive area, and then you partner with Dr. Geoffroy to kind of make sure things are lined up as they heal and move along. And that's how it works, right?
Yep. 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 I think at least I can talk from my perspective that my results have improved tremendously since we've been working together. I got stuck sometimes with patients where I didn't know what to do. I felt like I was making it worse. And I don't think I treat anyone in that area anymore before they've been seen by Geoffroy. They all go to him. Yeah. Yeah. And with me is the same thing. Like the more challenging cases, like where I was reaching the top shelf, like where I said like, okay, these piece of patients are too unstable or they literally they need additional help. Well, I'll send them also over to Anita. So we have like this traffic coming back and forth, which is a really nice way of working together. And it's also really nice for the patients because at least they know there is another stop down the line, which perfectly fits in our treatment schedule.
I think that's really smart. In my case, I've had four treatments. After one of them, I had C0, C2 PRP, and I was like getting better. I was making progress. It was so weird. I woke up in the middle of the night, and I woke up on my stomach, and I was like, "Oh no!" And I tried to turn around, and the world just started spinning out of control, and I couldn't find my phone, and like it was one of the most terrifying moments in CCI I've ever had. And so I called the physician who did those injections the next morning, and he was like, "Well, your atlas might be out," and that was it. He didn't tell me like I didn't know what that meant or anything. This is years ago, and he's like, "Maybe get it aligned up," and I'm like, how do I do that? And got almost no advice. And anyways, long story short, I went to a Nuka place, but it was like the lowest level certification. And not to badmouth her, she was great, but it didn't do much. I still had spinning room sensation, all this weird stuff. Kind of didn't do it at all for about a year. I did it for a long time, maybe 3 months, twice a week. Didn't really feel anything. Kind of just dropped it. And then recently, I started going to the highest level of Nuka, the board certified guy, and like do feel a little bit of difference. And I wish that early on, at the very beginning, when I started to have very early symptoms, I had a team like you that was like, okay, go here, see what happens, stop, go left, whatever. So I think that's really smart to couple those things together.
Yeah, and some of them, my patients have already seen a chiropractor or have they've been, it has been caused by a chiropractor. So I really have to tell them, no, this is completely different. Don't worry. And on the other hand, also like, I know your chiropractor is probably very amazing, but you need to see him anyway.
Yeah,
Um,
it's hard to find the good chiropractor, and also from an upper cervical perspective, it's like realigning the CCJ. It's really a challenging thing, and it depends on patient to patient. And I've had so many cases where it's like literally like playing around with a couple of degrees, trying to find that perfect fit, but you can't be going to an upper cervical chiropractor and being over adjusted every single time. Like he really needs to be finding a way of making the adjustments hold and making it happen that you stay in the ideal position. Because the real goal of upper cervical is actually to not having to treat the patient. And if I don't reach that level, like for example, I'm trying to puzzling this thing around and this is not sticking around. Like I'm right now thinking of a patient we have from Denmark. Like I send him over then at a certain point to a Dr. Anita, and she takes care then of trying to create a stability via the injections that she does, via the PRP and the Prola injections and the other variants that she does in that arena. But then what I see, like when I see that patient back, suddenly he's holding. He's better in alignment. The muscles are activated, the ligaments are activated, and my job makes more sense then. Like, and that's a really fun way of helping patients.
and what does that look like for you? So at what is it like, generally I'm seeing this level of these symptoms and it's been this amount of time and you go, okay, at this point, let's lick our wounds and send you to Dr. Anita, or is it kind of go, I'm sure it's patient to patient, case by case, but what does that generally look like?
Well, it's a bit like that. I think it's like clinical experience plays a lot in this. Like knowing if like what's the reason why this patient gets out of alignment? Is it because he's acting like a fool and not taking care of himself? Or is it truly because like I'm making a mistake? For example, I could be the one giving the wrong adjustment. Or is it truly like, no, this is really the adjustment. I've looked to all the possible imaging. I flipped everything around. I looked it through. I literally know this guy inside out. It's not sticking, and it's clearly signs of like misalignment and ligamentous instability. And then I go like, I'm sorry, my friend, but there is no point of me keep on hammering that bone without having some aid, some like artificial aid, we could call it. Like, and this is then back again to Dr. Van Domselaar.
Yeah, some kind of intervention there.
Hmm.
Um, and Dr. Anita, so what does that look like from your end? So at what point do you go? I mean, so by default, anybody who gets the injections, I think you mentioned, goes to him regardless?
Yeah, yeah, definitely. I've, I mean, it's maybe better, not as good for business, but I only have to do one injection. If they're corrected like he does, they come to me and they need one. Well, maybe they need two, but they have such a big improvement. Before that, I was, one, two, and you go like, okay, three. And I have a couple that are still there and they're making small improvements. And I try to convince him like, this, I don't mind you coming and I love injecting, but coming every 4 months for injections, I think we can do a lot better than this. So I'm trying to convince these guys who've been with me for a while to still go see him. But yeah, so I think since we've been working together, I only have to do like one or sometimes two injections and we're done. Um, so that's really good for them, right? They make steady improvements. Yeah.
Cool. Yeah, I think that's a big gap that we're finding with regenerative medicine as a whole. Is like as patients, we're so used to like, strep throat. I show up and you swab me. We got this. Okay, cool. You give me a pill. And then within a couple of days, I'm like, oh, okay, well, I'll be on my merry way. But with regenerative medicine, it's like we're trying to avoid anything super invasive like a fusion. And it's not a pill for sure. It's a matter of educating yourself, changing your habits, and doing things over time to try to heal and regenerate. And it's this slow step by step. It's work, is what it is, and that in education, and it's challenging for patients. But yeah, so that's why we're trying to get this info out to people.
Yeah, yeah,
Yeah,
it's I've stopped completely with doing classical anesthesia and pain medicine. So I'm so addicted to
Mm,
the regenerative medicine because it actually makes a diff. I mean, the other part makes a difference too, but this is different. Can actually still work on some kind of a cause, while the other pain treatments are just symptomatic. And I think that still has an important role, but it comes at the end of my treatments. So first I try to still, we still try to fix some things. And then if the nerves are still agitated or some other things, or you need some Botox for these muscles that keep going into spasm, great, no problem. But it's at the end. So it doesn't come, we don't start with that anymore.
makes sense. Yeah, a curative versus just kind of treating the symptoms and having you come back every 2 months for the rest of your life.
Exactly. Yeah.
Um, cool. So, and on that, could you talk more about how you started in pain medicine? So you went to school in Europe, I assume, and what
Yes.
caught your eye for pain specifically?
Yeah, so I'm Dutch, but I was born in Belgium. So I did most of my studies here in Belgium, and I did anesthesia. I always thought during my internship that those are the cool guys, they come in and they're all relaxed and they save the day, and then you just go out for coffee again. So I think, you want to be able to save a life, and then get time to figure out what's going on. I thought they were really cool. So I started doing anesthesia, but then I noticed that I was more into the softer things. I like to do the injections. I like to do a regional anesthesia while the patients were still awake. So actually, just putting them to sleep was not really my thing anymore. So I spent a lot of time at our local center. So it's a university center, multidisciplinary, blah, blah, blah. But then again, I was a bit disappointed in all that, the things that we had. Spent a year at Toronto Western Hospital as the interventional pain fellowship, so very prestigious one. And there, it's very different here in Belgium. Most pain docs are anesthesia, so they treat backs and necks. Um, so in Toronto, everybody can be a pain physician. That might be in the States as well. So you can come from all disciplines, and then you just have to, do everything. Everybody needs to know everything at the end of the training, and which was awesome, right? So I learned to do MSK and had to catch up on a lot of things. A lot of ultrasound guided procedures. So and then I did another year of training in ICU, but then when I got back, I decided to start my own clinic and just um, yeah, all like in Belgium, a lot of things are reimbursed, mostly everything. So patients are not really used to paying things out of pocket. And once as anesthesiologists, you move out of the clinic. Um, yeah, all your patients have to pay for everything you do, which was a bit of a transition for me as well. But then I decided to just go for it and just and provide treatments that were not being offered in the hospital, which turned out to be amazing. So I because I was ultrasound trained, MSK, regenerative medicine was like a very obvious next step. And then I decided like, hey, but I'm anesthesia. I know how to do necks and backs. How am I going to make this work, right? What am I supposed to, all these devices were created for knees and elbows and like joints. And I was like, how am I going to, how am I going to use this to treat the entire neck and an entire back? How is this? This doesn't make sense. So then I joined Regenix to see, like see what they were doing. So I'm a Regenix provider for just normal spine, lumbar, thoracic, so just cervical, not upper cervical. But so that was great. That was amazing, seeing how they were treating their patients, as if the neck and the back as a functional unit, all treating everything at the same time, which was great. I was trained like, oh, let's do facet joint joint, and then in 2 weeks let's try the other facet joints, and then maybe we should do a TF, like get transforaminal. So after a year you went through everything. But so this is pretty amazing. You can just take as much blood. I mean, with our um equipment that we have, we can take as much blood as I need. So I'll go like, oh, I need this concentration or this dose for this joint, and I want this for this ligament. And like as he said, I create cocktails, and I want Prolo for that, and I want just plasma for that, and we'll just calculate how much blood I need for that, and we'll take it. So it's really cool to be able to do that.
That's awesome. Yeah, Regenix is a great company. I've had 3 out of my 4 treatments there, and was treated really well, and obviously legends in the space. So nothing but respect for them and Dr. Centeno. Um, and Dr. Geoffroy, same for you. How did you get involved in Blair? What was the come up like?
Yeah, it's a good question, this one, because actually, like, of course, upper cervical is basically non-existent in Europe. So I was just regular chiropractor, cracking and snapping backs, I would say. Um, and unfortunately, I did not enjoy it to the point that I was asking too many questions, like what am I doing here? Like, is this actually helping? Because you would see the yo-yo effects in treatments, and I couldn't do any consistent work, not even calculated, I would say so. And so I started going actually to the US for training. I'm the only diplomate in craniocervical junction procedures in Europe. So that took me about 4 years of traveling back and forth once a month, up and down all over the US where we had our different classes. And that actually brought me then really deep into the tunnel of upper cervical. And I was very fortunate of having a lot of the technique presence, you could say, were all in my class. So I was really like very involved with the tops of the upper cervical niches. And I became really close friends with them. And of course, with the friendship comes mentorship. And with the mentorship comes a lot of night calls and a lot of additional training. And like that, I became better and better in Blair. Like it was my technique of choice. I'm not saying that I want to stick to Blair. Not because I don't believe in Blair, just I freaking love Blair. Like I think it's such a good approach. If you're a good Blair adjustment, I think you clear the articular part of the neck amazingly. But I love the orthogonal mindset behind the orthogonal work, like Nuka, AO, Advanced, like the whole line. I really like the thinking of it, and I'm starting to play more and more with posture and trying to really get that neutral head tilt as well, which is quite hard within Blair, but then like it makes me now look at images differently and makes them flip them around and positioning patients in different angles so that I can find that more neutral adjustment. So it's a fun way how I also managed to get like these couple of percentages more advanced, like closer to neutral, and getting the patients to hold even longer, of course. Like yeah, that's the main goal behind everything.
Cool. At least in the CCI world, from what I see and from my knowledge, yeah, Nuka and AO are the two that are mentioned 90% of the time, and Blair comes up every once in a while. Maybe it's just not so popular in the US, or maybe it's just people that read my stuff. But could you explain the difference between those, between AO, Nuka, keeping things orthogonal, and what Blair is? How does Blair work?
So if we talk about upper cervical, there are two main lines that go down. One is the articular work, where you would look more at the joint, like at the spine from an articular perspective. Meaning, like if I go closer, like for example, it misaligns like there and C2 and the opposite way. I would be looking at this joint and that joint to seeing how I can combine both to get it back neutral. Um, but the idea is to try to realign the articular spaces between joints, while in AO or NUCA, AO will be with a instrument, NUCA will be also with hands, but the idea is practically the same. Like, of course, the real people who know about it will say there's a lot of nuances, but the idea behind it is trying to create the right vector of realigning it by moving two shapes on top of each other. So by moving these two, that we realign the skull and the spine um, via vectors. So it's a different way of looking at it. It's more via vectors, how you can move like a fulcrum, while an articular technique will look more locally, segmentally. But from a segmental point of view, it's really interesting also. It makes you also think faster about like Anita's work. Because like articularly, she's also thinking at the end of the day articularly. Not saying that Blair is better, Nuka is better, because it really depends like upon like the practitioner. Like, you know, it's like anything in life, like you have like a good carpenter and you have like not so good carpenters. Like, you know, I'm not saying that the not so good cannot become great. It's just like it takes a long time and it takes a good guidance of seeing what's doing the good job and not doing the good job. And that's I think also something that's really strong between me and Anita. We're both very perfectionists in trying to improve our craft. Every single time like that we talk to each other, and I'm sure Anita will say the same about me. Like you know, she's always busy with a new project. She's always looking and trying to refine the craft, trying to get deeper. And I think if I may talk about myself, I think we're pretty deep in the tunnel already, and we kind of know what we're doing, but we both know that we don't know what we're doing because we want to know more. Like, you know, we just keep on digging deeper and deeper and trying to refine the perfections within both our jobs. So it's very nice.
Yeah. That's the problem. The more you know, the more you don't know. Or the more you, yeah, the more you still feel like, oh, there's so much more out there. I need to, yeah. It's endless. It's never gonna end.
A deep tunnel. It's a very
Yeah.
deep tunnel, but once you're in it, it's okay.
Yeah. And I say this almost every single day. It's this whole thing is just so under researched and new, and it requires things like what we're talking about today and what we're doing right now, which is, open discussion, collaboration, these sort of things, and not operating in these tiny little silos because these patients are suffering so terribly. And I'm doing great now, but I've been there and it's dark and it's really confusing and there's no info and it's tough. So I respect what you guys are doing. That's awesome.
Thank you.
Um, and Dr. Anita, so the clinic, could you talk about your equipment in the clinic? So you have DSA on your C-arm fluoroscopy, things like that, right?
So I work at different places. So we're expanding pretty fast now. So I don't in my main clinic in Leuven, I don't have fluoroscopy. I have another clinic where I can actually do fluoroscopy. So I do a lot of procedures that I can do ultrasound guided. I'm very trained ultrasound guided. So I like it, especially the cervical area. There are a lot of structures you do not want to hit. And I feel more secure using my ultrasound, not for C0, C1, but from C1 down. There's actually so many things that you can see with ultrasound that you would never be able to see in a fluoroscopy. I mean, you just see bones. So not being able to use contrast in some cases, I guess, yeah. But I really just really love my ultrasound. For C0, C1, definitely. I will go. I'll go to a different spot, a different place, and use contrast and have my fluoroscopy guided procedures done. But from C1 down, I actually tend to use ultrasound. I really like my ultrasound. Yeah.
Really quick, just to jump in, I asked the DSA question, and then we kind of got distracted with other things. But I went back and asked her about that just to make sure, see where her thoughts were. So I said I wanted to reach out directly about does your C-arm have DSA? And she said this. Thanks for the reminder. It does. And to answer your question, when you inject under fluoroscopy, it's essential to use contrast to visualize your spread. And most important, to make sure you're not injecting into important vessels like the vertebral artery. When using ultrasound, you can actually see vessels in the spread if you're injected. So as long as you're not aiming for the epidural space or C031, my preference goes to ultrasound. And but I also have pretty lean patients, which also helps with the decision. So I can't speak on that. I'm not a doctor. Again, not medical advice, but that's her answer. So here we go. Keep watching. Cool. Again, none of this is really researched or standardized, but some positions will say like only C-arm, but then other positions will do, they're clearly high level and have been doing maybe thousands of procedures, and they say similar things. Like I prefer ultrasound, so I guess having whichever tool you're most comfortable with, is
Exactly.
best.
Exactly. It's imaging, right? And so you cannot look past bone with ultrasound. Definitely not. You can't do that. So if you want to confirm that your spread is going into some kind of area that's covered by bone, then you need your fluoroscopy, right? So that's how it works. But on the other hand, looking at tissue, there's no tissue on your fluoroscopy. You just see bone. So you're just kind of like, okay, with an average patient, if I take the middle of this joint, I'm probably gonna avoid vessel nerves and everything like that. You don't have that ultrasound. You just see it and you go like, "Oh, great! I'm glad I'm using ultrasound because it's like the vertebral artery is right going right over where I was gonna inject." So I really like my ultrasound, I have to say. Yeah.
Interesting.
There's
Um,
also a certain art to it, huh? Like it's however you're most trained in. Like, and Anita's like as an artist, like very she can move around. Like there's a certain amount of like flexibility and angulations that you can do with the ultrasound, which is nice.
He was treated recently, so he showed.
Yeah,
That's why he's saying this out of experience. Uh, no, I've spoken to many radiologists, and they actually confirm like C1, C2 is pretty, pretty awesome under ultrasound. It's not easy. It's not easy. I think it's for sometimes especially with a bit larger patients, it is easier to do fluoroscopy, but ultrasound is very rewarding. I like it a lot. Yeah.
that's cool. Um, how many upper cervical treatments have you done, Dr. Anita? How many patients
I
have you
would
taken care of?
I would say so no, I mean, I've been active since 2019, working privately. So I think I'm not up to 1,000, but we're like, I don't know, somewhere at 500, something like that. I think around that average, yeah.
Cool. And same for you, Dr. Geoffroy?
Me?
Yeah.
I have I have in my I think like in my database I have like over 2,400 patients now. So like that I've been treating over now the last couple of years. So it's quite like my office is growing actually quite a bit like lately. Um, but yeah, like there's a lot of adjustments. I can't say how many adjustments because of course I have to do sometimes more procedures than Anita does. Like, like we don't count our adjustments. Like I should do that. Maybe that would be a cool statistic for like one day. Like, that you can see like over time, like how many adjustments regularly a general patient needs. Let's say like a regular patients, they need like in a treatment care of 6 weeks, probably there will be once adjustment, maybe twice. A really bad case can be more. And then they know I'll be starting to think and starting to get annoyed at myself and like starting to dig. Like, and that's like 4 or 5 adjustments max. Like, then I stop. Then I go like, job done. Like also something really good. Dr. Scott Rose, I don't know if you know him.
Yeah.
You must, yeah, okay. Dr. Scott Rosa. Um, he has an expression like something like, yeah, if you do an adjustment and it's a landmine, don't go there again. Like refer out first to for injections or like further imaging that you know why is there a landmine, and that's also like something I really take to heart.
What would be an example of a landmine?
Well, for example, you adjust and patient gets really sick, nauseous, like overwhelmed, really bad reaction during the days that follow, extra vision disturbances, like stuff like that happens, but it's very rare. Like I always say to my patients, like generally there's a very big group of patients that will just say like after a first correction, you will feel as if I did kind of nothing, but it will feel slightly different in the neck. Like, the adjustment is super soft. Like, upper cervical, you wonder, like, was that really even an adjustment? Like, did something really happen? And that's upper cervical. It should be like that. If you really feel like your neck is being pushed and pulled and smashed, you're in the wrong place. It should feel super light, and you should wonder, did it happen? And then the big group says, I felt okay. I had no bad reaction. I just felt my neck slightly different. And coincidentally, I had an improvement in my symptoms. That's the general big group. If you would have a counter, like a negative reaction, generally it consists of three groups. It's one group is headache, classic. Also will be the headache patients who will get the headache after the adjustment. It's not a bad sign. It's just your body reacting. The other one is a slight dizziness, a little bit like feeling slightly high, a bit woozy. And the last one is fatigue. And why fatigue? That's how you recuperate. That's how you heal. That's your body put like having more neurological connection and putting you asleep actually, so that you can heal. And so it's the three most common signs. The first thing that I said in the beginning, it's such a rare peril, like that happens super like often. Like our worst cases of me and Anita, like I'm sometimes really scared, and then we talk to each other, and I go like, oh really, what do you think? La, la, la. We go over stuff. And then often these patients have fantastic results. Like, like it's really interesting. Like how sometimes like a light case, an extremely difficult case can have such a light result just because like you release all that nerve pressure or carotid sheath pressure.
Yeah. I had my when I started going to the board certified Nuka guy in January, kind of always had this weird funky feeling in the like occiput in the right side, and when I turn my head, it sounds like gravel. It's like
Yeah, like
really,
stands
really,
grind.
yeah, it's really, really odd. And it's been constant for I don't know how long. I forgot, maybe a year, whenever the injury happened, whatever. Did the adjustment, and first we did those measurements where he weighed your feet individually, see how much weight and all the line up and all this stuff, and he was like, okay, I was holding like 8 kilos or 19 pounds on one foot. Hips were way out of whack and twisted, shoulders, neck, all this stuff. He did the adjustment, and honestly I was really skeptical because previously I did it for so long and didn't feel anything, and I don't know, just it's so
Yeah.
understudied, and I'm really a natural skeptic, and I was just like, I'm just gonna try it and see what happens, Ben. But just letting you know, I don't, I have zero expectations. So he did that, did the adjustment, saw my feet were. He didn't even tell me about the feet weight thing until we did both measurements, and I was like, oh, I didn't even realize there's scales under there. And he's like, yeah, you went from 19 pounds to 1 pound. Here's all the other stuff. And he was like, you need to like go home and go to bed and like rest for 3 days. And like that night, I felt terrible. That headache shifted from over here to over here, a little bit of dizziness, and some other just weird symptoms that just got worse. But then within like the next morning, I woke up and I turned my head and I was like, oh my God, it's like butter. It felt like completely different. I don't, and it's been maybe 3, 4 months, and that sandy, gravelly stuff will come back for maybe an hour every couple days or so. But I mean, even right now, it's like butter. It's really, really weird. And so I had a not a very good reaction to it, but I was prepared for that. He was like, "We did a
That's
big
okay.
thing here," and
If you if
but now
you
it's
if
now
you
it's great.
warn, that's awesome. If they warn you, then it's awesome because then this is really a very possible thing. It happens to my patients. Smaller percentage, maybe 10%, but it's a normal reaction. Like it's really cool. And then he also measured your posture pre and post, that you can see like how the whole body shifts. It's
Yeah,
crazy, yeah? It's
it's
crazy
weird.
with so little.
It's so
It's
weird.
So
really I love it. I had like my also Nuka adjustment in November, I think, by Dr. Jeff Schulten. Don't know if you heard of him.
Mhm.
Absolutely hero. Like he's incredibly knowledgeable. Like yeah, super smart guy and an amazing adjuster. And I also never had a Nuka adjustment up and down. Loved it. The sensation and the connection. I was like, I also felt sick. I actually got sick afterwards. Like
Mm.
the day after, I got feverish. I had a cold, feverish cold. Like, I was just not feeling well in myself. And after that, like, wow, symptoms. Poof, I just went great.
I have to
Wow.
tell every patient that they're not going to be well after my procedure.
Yeah.
Otherwise, it's not going to work. I should tell them, I really hope you're going to be really bad in the first couple of days because otherwise, what have I done? So
True.
yeah, well, not, I mean, really bad, but like a lot of symptoms
You need
and
a reaction. You need the
yeah,
body.
you
You
need
need the
something.
body needs to
Exactly.
say something like something happened.
Exactly. Yeah. And if you have to explain it to them, and that's why I understand that regenerative medicine is not for everybody. I can understand why orthopedic surgeons really dislike this treatment because your patient first is going to be worse, hating you, and then they're going to be the same, and then eventually they're going to get a lot better. But it's waiting for that getting better, that's something I think surgeons are not really excited to wait for him.
It's actually
And
two therapies that need a little bit of faith, that you need a little bit of faith in the therapist. Like, the therapist has to know its procedure and there has to be a certain kind of relationship between doctor patient that he knows like, okay, I'm just gonna follow this through. Because if you stop like at week one or at injection one or at oh, it did not work, and then you're angry, and then you go about. No, you have to trust like that is gonna work, and if it's been delivered by the good therapist, it should normally have an effect. Like like
I
should
tell them
be.
they're going to be, yeah, they're going to be rewarded. The people that suffer in the beginning are going to be rewarded. They have the best results. I see them every time after 2 weeks, just applaud and go like, "You've done great. That's what you had to go through, and now you're done. Now you're gonna get much better." And if you explain it to them really well and they expect the worst, it's not going to be that bad. So it's just I give them a heads up
Yeah.
that it can be really bad. But like since we've been working together, I don't have the huge. I used to have some that were horrible, but they were just not aligned. And if you then put some, inflammation on top of that, they were horrible. That was not fun treating these patients.
Hmm.
Yeah, that's one thing that I really love about our teamwork is that I I think both, but I don't see the sense of injecting something that's crooked. If it's in this position, like how many injections will it take to get this thing aligned? Like
Not
impossible. Like like
large
well,
volumes from one side, maybe.
yeah,
They're
lift it up,
pushing it
pick
the
it up.
right way.
So it's just like that combination of thinking of how can we put the chain back on the cadence of the bike and then fix it and tighten it up, like tighten that chain in the good position, and then give the patient the confidence of like, hey, take it for a ride, and we take a little bit of distance between here, like and is his body holding, is it staying together, nice, lovely, okay, great, hope see you in a couple of months. I think that's the really a way of healing that we're providing instead of like just like pain management, which is often what you go for a chiropractor for in crisis, or you go for to a healthcare pain medical healthcare centers for injections of cortisone, trying to mask pain. Like it's not what it's about.
Yeah. Yeah, totally. And I couldn't explain to you the cellular biology behind it, but I'd imagine that in some of those, convex joints, if they're smashing up against each other and they need to be releasing like those cytokines and those signals to the stem cells and all that stuff. If it's squished, I'm sure that doesn't let them release their signals, and it's not going to heal as well. So I think it all does have to be lined up and tell your body this is the direction that it should grow and lay it down like this and all that. So that would make
Yeah.
sense.
So
Yeah, and
the
also because the inflammation, I think, kind of fixes in that. I'm sure you have, because of the CCI, you have mobility, so you'll have at times, you know, it will be in a better position, and if they come in their worst position and you make it swell and it stays fixated in that position, that's just, those symptoms, they get out of control. It is yeah, so I mean that's about the acute phase and making it worse, but exactly like you said, you can and then that's why we do the correction, and then you can actually heal permanently, right? If we do these regenerative treatments, and you give them all the growth factors, you give your joints everything they need, and you heal these capsules, you make them stronger, you get these ligaments to become stronger, so everything becomes more stable. That's what you need. Yeah, but once first you need to get in the right position.
Yeah.
Yeah, the body craves like something really cool. It's like a combination between like the body basically craves a balance between stability and mobility. And I have a couple of friends, and they called it dynamic stability, which is a great name for that. Like it's a dynamic stability. And for the patients that will be listening to this, like you just consider that you have the top vertebrae, the atlas, and the occiput. They are basically an immobile joint. They have like 0 to 3 degrees of motion, like basically no motion. And at the same time, you have then the dens, so C2, with the atlas, which creates the most mobile joint in the whole body. So you have like a super complex structure with a bowling ball of a head of 5 kilos on top. I don't know how many pounds that is, but a lot. So it's like super hard to stabilize. And of course, if you get like a whiplash or you're using all the time your phone, there's like creep happening in the spine. Like joints can get misaligned. And with a misalignment, you can have like a problem arterial flow, venous flow interruptions, or CSF flow interruptions, all of the because of the bad positioning. And then of course we haven't even started at the neurological components behind that. So then when you get the biomechanics good and there becomes a dynamic stability, and that dynamic stability with ligaments instability gets injected, realigned by me, boom. Suddenly you have a stable structure, and both of us we back off and we let the body heal and do its own way. Like, it's really
And then
cool.
yeah, and then we haven't talked about, these muscles that are constantly in spasm and these nerve being entrapped and everything. And so, I used to, that would be the first treatment that would I apply. Like, oh, nerves are being entrapped. Let's just burn them. Muscles are going into spasm. Let's put some Botox in them, right? And so now they've moved all the way to the end, and sometimes it's not necessary anymore because the muscles relax. The nerves are no longer entrapped, and they calm down. And if that doesn't happen, we still have, our old school treatments, but we don't have to do that. That's how what I tell them. Just see where we end, see where it goes, and maybe you don't need me anymore. We'll see.
And it's sometimes really obvious why these muscles go into spasm because there is ligamentous instability or ligamentous damage. If the ligament is broken, something has to hold this bone together. Okay, backup plan is the muscles. So then what is the point of doing, with all the respect, PT? Like I love PT. Like I also work with an amazing PT neurokinesiologist. He's amazing. But like these muscles are in spasm. You don't need to release them or inject them and make them even more fatigued so that we have even more pressure on the spinal cord or on the other arterial structures. Yeah.
Yeah, I mean, all that makes a lot of sense, and that's pretty much what I saw too. The very first thing where I was like, "What?" I sort of get dizzy at the grocery store, and at that same time, the front of my neck was so tight that like if I open my mouth to take a bite of food or talk or whatever, it was like it was just fired like a rock. And I this was very early days, and of course later I found out that that was a connection to those neurological things. But um, yeah, I mean that's just that's what happened. And then as I've gotten treated, now my neck is relaxed and normal and back to regular range of motion. I couldn't move my head past like literally like 5-10 degrees, and all that's pretty much gone. So it's a tall order for patients because it's so weird and you have so many symptoms that just get dropped on you, and a lot of those are undiagnosable. I mean, a lot of that dizziness and all that affects so many people. And how do you even diagnose dizziness to figure out where the source is? It your inner ear? Is it a proprioceptor? Is it something with a nerve? Is it something blocking any of those things? Is it blood flow? Is it the brain? Is it whatever? And I don't know. It's tough. I mean, for me, it was kind of a process of eliminating everything. I got all the MRIs, make sure I'm not having a stroke, heart attack, investigate all this stuff, all these scans, while I'm also chasing the neck thing and treating that. And hoped, in my case, I was just like, I hope that this does it. And luckily, it did. It disappeared. It made all those things disappear. But it's a tall order for patients, especially because the diagnostics are just they're tough. They're hard to come by, and they're um, not super standardized and all that. So yeah, it's tough.
Yeah, I mean, I'm used to that, but I see patients usually after years and years of going through seeing doctors, specialists, scans, and more scans, and another scan, and maybe it's still progressive. Let's do another scan, and nothing comes out. Yeah, that's I told you about this before. Like, there's this woman from Switzerland or something like that, and she had an upright MRI done. And I'm like, wow, that's pretty impressive for symptoms that have been going on for 6 weeks. I'm like, wow, that's really crazy. I've never seen in person. She's like, I was on the internet and I thought I had CCI, so I just had an upright MRI done. I'm like, okay. So I was, but usually we don't see these patients.
Yeah.
Yeah,
Um,
what's interesting is that everything about the craniocervical junction, like all the symptoms of dysautonomia that come around there, it's like patients travel in a tunnel in between healthcare, and most medical professions don't have a grasp on that tunnel because, like, imaging wise, a brain scan goes from skull up to maybe C1, and then the next scan is usually C2 down to the T2 region. So it's a really interesting region, like that this part is often ignored or on slices not sufficiently examined, except by really adequate neuroradiologists. But a regular radiologist will just easily say, this is normal, this is nothing that significant, which I understand also because it's really, you really need that additional information about it. So patients often get undiagnosed or misdiagnosed until you get somebody who really understands the region. It's a really weird thing of traveling in a tunnel. Like that's what I often see with these patients. And then you have
But
this
also,
unique.
yeah, but I do think that once our treatments become a little bit more recognized, radiologists will start to look for these things because right now, what are they going to do with it? You know, if it's not a clear ligament rupture or a fracture, I mean, there's no, what are you going to do with it? It's probably
I
just
know.
a find like a how do you call it? An asymptomatic finding, or they don't really know what to do with it. As soon as they realize that there's a treatment for these things, they will look at it differently. I'm sure they will. Yeah.
They wouldn't even know to who to refer the patient as well.
Correct. Yeah, exactly. Yeah, they usually work for the surgeons in their department who have specific questions, and that's what they answer to. And I mean, obviously they look a little bit further and see if they're not missing anything. But yeah, they don't know what to do with these things. And so I think we're talking to a radiologist in Belgium, who I think she's starting to open up a little bit to working with us and getting more on our specific imaging done. And yeah, so I think we're making progress in Belgium. Small, but we are.
hmm, that's awesome. Yeah, I mean that whole thing for in my case again, like I had four MRIs done, and this is before I knew it was a neck thing. And for all those MRIs, the radiologist is just like, dude, you're totally clean. I don't even know what's going on. And I'm like, I can't walk, and like I'm having massive trouble. I can't take care of myself. Um, So I got a second opinion. I hired another radiologist, same thing. Hired a third one, same thing. And it put me through such mental anguish because I'm like, I know something's wrong. Why can't anybody find this? And I was asking the wrong question the whole time. So it's just medicine's not perfect. People fall through the cracks, and this is one really, really, really tricky example of that. So it's tough. Yeah,
Sorry to hear that. Yeah,
it's all good. I'm doing good now.
that's good. That's good.
Yeah, that was a tough time. So on that with diagnostics and moving along, moving patients along this path, do you guys have any like before and after sort of case studies? If you guys got a lot of bunch of imaging and stuff, do you have any case series, case studies at all, or anything that you could put out or that you have out?
You're probably, or do you have imaging ready, Geoffrey? Or we just, because we talked about two cases, right? That we wanted
Yeah,
to share.
to share. Okay, sure. Yeah. I thought we were going to verbally share it, but I can
Oh,
share on the.
verbally. No, no, I don't have anything to share.
Oh
I'll
my.
share verbally.
Yeah, no, no. We like we have many pre and posts that we do. So usually they come to me. So what we talked earlier, me and Anita, we were talking about a Dutch patient of mine. Like there's often international patients coming in, and then we at the like lately we've been doing even like these weeks where we trying to see everything in one go. Like that there's a nice natural flow for the patient, which is also really an important factor when you come from abroad. But so we have this one patient who I was struggling with, and he hasn't been diagnosed with Ehlers-Danlos syndrome, but like my finger is saying this is Ehlers-Danlos syndrome. Like, there's no doubt about it. There was no stability into it. Massive.
I think he did. I think he did get a diagnosis. I
In the
think he
end, he
finally.
did.
Yeah, I think he finally did.
Okay,
Yeah.
because I know he was on a waiting list for that.
Yeah,
Oh, he
I think he
already
did.
has it. Okay.
Yeah.
He didn't
Mhm.
even tell me. Okay.
Yeah.
Um,
Doesn't change anything for us, I think, but I mean, now he has it. That's great.
that's one thing that we can glue on it.
Yeah.
And so I have like from him. So wait a minute. Let's go into Stan back. Wait. Give me 1 second, guys.
Take
So
your time.
sorry. I wish. Um, so just so I can open the imaging. Uh, up.
And Dr.
So
Anita, while he's working
yeah.
on that, do you guys ever? I know DMX, digital motion X-ray, is hard to come by in Europe, but I think there's one in Italy or something like that. There's some
Yeah.
obscure place that has it in Rome or something, but um, most X-ray places or Dr. Centeno's put out some directions for static X-ray places to
All
do
that.
the
Yes.
stress test stuff. And that's starting to hit, and it's doing pretty good. Do you guys look at those, or what's your typical like requirement for I need this before I could do this?
So the DMX is something that we're working on. So I think our radiologist, it's a neuroradiologist, she's brilliant, PhD, and she was open to looking what we can do in Belgium. So in her hospital in Limburg, where she can have that done. So for now, exactly, we have to send patients abroad, and if we're lucky, they'll get the right imaging done. For now, we usually have just like static lying down MRIs, confirming that there's nothing wrong, and then. You have his, then they go to Geoffroy, who has another CBCT done, then he compares the images. So that's what he's working on right now. So no dynamic scans that we have for the moment, and I don't think we really require that. So I mean the lying down MRI confirms that there's nothing else going on, so that's also one thing. I mean, it's tough for patients, but it's also important to know that there's nothing else going on. I mean, it is important. And I think based on the clinical, like the symptoms, clinical examination, and then we add another CBCT. So that's what I think also Geoffroy's looking at right now. Confirms then that it's very suggestive for CCI, and then having these treatments done and seeing that improvement only confirms that we're what we were thinking about is correct. So,
Yeah. So what we also, I think at some points I wanted like in NUCA you take like NUCA and orthogonal work you take pre and post imaging. In Blair you rarely do that, just because of like our listings change less fast than a NUCA perspective. And also, I think like over imaging is also not the best thing to do, but it's something I'm really looking forward to, mostly because of case studies. Like, of trying to do, like to show, like, and do an RCT, show like what we're achieving. Um, in combination with that, the DMX, like we're looking into it, like with video fluoroscopy, but DMX is a brand of video fluoroscopy. So this is one way. Like there's also like I know Sasha does one in somewhere in Canada, which is like a variant of it. Like there's many differences. Okay, so here, by luck of this guy, we have a pre and a post. So if I can share here, yep. So we're looking with me on my screen. Um, so first of all, we have like a sagittal image, axial and coronal. And so basically here we see like first there's very lots of straightening of the cervical spine for me. So this is also a straight spine. There's a big kink. So meaning that potentially there will be some ventral compression over here. Potentially. We don't know that for sure. We need an MRI for that. When we look from the top, I go down. And I can see already that the atlas, if I go maybe a little bit thicker, up, there we go, up. What we can see is that the atlas here is already actually surpassing a little bit and potentially giving a little bit of compression here around the right anterior stylet process, but not majorly, just minorly. And now when we went down, what we can clearly see is that there's a certain kind of kink in the pattern. Okay, so we can see that this is more like then from an orthogonal point of view, we can see that the atlas kind of shifted, C2 went this way, and then we have C3, C4 going this way in very basic terms, so that we can see like, okay, this, I mean, you don't have to be a magician to understand that this is like not in the right position, okay? And so this guy is a guy who was, he's now 22, he was 21 when he's there. Sadly, he could not leave his house, couldn't even study anymore because of, yeah, because of, um, of
multiple
yeah,
pain complaints as well, right?
super big dysautonomia case, like,
Yeah.
and I saw him, I think, like by coincidence, I think 3 or so weeks ago, and the guy says like, I'm starting to cook again and standing up in the kitchen, I'm doing my life again. He's still like not like full on fitness, I want to go sport, I want to go running. He's very careful, prudent, which is a good thing. I'm happy that he is like that. But he's gaining so much stability since the injections. Like the correction was everything, but then these injections pushed this guy forward. Like, it pushed him really like on another level. So I'm going to go then for the post. So I have to stop sharing and get into the other styles. So 1 second.
So,
Oh,
Jeremy, the other thing with him is he had a lot of other pain complaints as well. So we had several subluxations, shoulders, hips, and everything like that. I mean, pretty straightforward. And also costochondritis. So a lot of pain. Yeah, just the shoulder area, not just neck. And another thing, what was happening to him, he had a lot of muscle spasm, which were not helping with these subluxations as well. So with him, I think neck was first, and then eventually we progressed. We went to, I mean, we've done so many injections on him, and he came back. I think the last one was November 2024, and we actually did. Again, the costovertebral joints with him, facet joints, lumbar, SI, coccyx, and then prolotherapy of a lot of his joints in an Botox injection of his eventually of his sternocleidomastoid. And that seemed to be work. That was, I think, the second time that we did like this big treatment with then some muscles that we injected as well because they are just, he's so hypermobile that these muscle
yeah.
spasms are just not helping him at all. So that's like a rare case where I would actually combine the Botox with the PRP, not in the same muscle, obviously, but helping out with this with his stabilization of his problems. Yeah. So
Yeah.
he's a great.
And the stability I'm seeing now from a chiropractic point of view, it's insane. It's literally like for an Ehlers-Danlos case, which every single time L4, L5 would be popping out to the right, a rib would be doing something. The guy
Exactly.
would be clunking all together. Now it's
Yeah.
just like solid
Yeah.
thing because why? Posture-wise, we put them straight, and secondly, where there was laxity, we're trying to stabilize. But this guy is really being like heavily injected. But this is the images now. If I can share this is not a CBCT, it's a variant of this. It's a CT. Okay, so here when we're looking at the cervical spine, you can already see the atlas, the dents that we remember from last position, and then the perfect alignment afterwards. So, it's really cool images, like when you see the difference pre and post from the top down. So here we go. Foramen magnum, nose nice and straight. We go, we go down. You can tell that this is already different. Underlap, this is a regular, normal over, like movement from condyles up to atlas. And then we go down and check the difference here in styler processes. Perfect. Just amazing position. Here we get in sideways, the sagittal view. It's not as, can I zoom out? Yeah, too much. Yeah, there we go. See, curvature is starting to recur, which is fantastic. And that's pretty much it on this guy.
Yeah.
So I wish we could do this on more patients, like pre and post, but it's one thing. This is Belgium, this is not America. Like, in the US, you're a bit more free. Like in Belgium, you're a little bit more restrained with these kind of things. But I'm really grateful that we are already able to doing this kind of imaging, you know?
Awesome. Yeah. Over here, the imaging, the whole diagnostic process is just odd, and again, not really standardized. We do, as you probably know, the typical thing, at least you go through like Dr. Centeno or most of these other physicians, is typically digital motion X-ray, the video fluoroscopy, or those static X-rays, and they'll put that into posture ray software that analyzes the segments and tells you which is where it's off and such. And that's maybe that comes up to maybe that comes down to physician preference, but I think that's what's preferred by Dr. Centeno and some of the others as well to figure out where those targets are injected. So, but interesting.
I don't know how good posture ray is though. Like, you know, because that's like I rather have like myself looking at the images than a tool analyzing the images because it's just a snap, you know, but that's just
You're the software.
yeah. And I just like to dig down, you know, trying to figure it out. Because yeah, there's also a certain craft to it, and I'm saying I'm really not good at it compared to some of the guys I know, you know, and I think it's a great position to be in.
Mhm. I've told patients many times that, yeah, if you're going for this, if you're getting this really serious like neck injection treatment, and that physician just goes off just like a two-paragraph report and doesn't actually look at the images, it might be a bad sign. You probably want to have them double check. You probably want them to look at the images too and get their own interpretation in addition to the report too. Um, Cool. And you mentioned you partner with a physical therapist. What was the term that you used? Is a neurophysical therapist? What did you say?
No, it's neurokinetic therapy. It's something I came across recently. It's basically to re-neuromodulate muscular activations. So what I often have is like, you know, when there's a patient with, for example, a poor knee or a poor hip or a poor foot, like these guys can actually muscle test. It's like a combination of applied kinesiology, but his whole treatment approach is I love it when you have a good one because there's many levels in that as well. But like they really muscle test every single thing till they find like a weak connection, and then they do just like also one thing or two things. Like, you know, it's not a treatment like a physical therapy where you come in and you do like all kind of neck exercises or you learn how to squat or jump. No, it's not that. It's really like muscular testing, what the neurology is saying. Is there activation or is there no activation? If there is no activation, how can I reactivate it and find the links? It's like PDTR. It's a different variant of that. PDTR is also like muscle testing with like reflexes and all kind of stuff. It's a bit more like yeah, I wouldn't say it's a bit more in the wushy part, but it's because it's grounded. The neuromuscular testing is like grounded. PDTR has little bit more play in it, like, you know, like a little bit more different stuff as well, like emotions or other harder stuff. The neuromuscular training is it's actually following the muscles. Is this muscle working? Yes or no?
So that's just trying to reset those defense mechanisms or compensations that you've gained along the way, that your body has just changed the way that it works. You're trying to go back to. So there's an example. There's the uh, deep. I think it's, yeah, the deep cervical flexor test where they put the pressure cuff behind your head, have you push against it, and they test to see if your SCMs are firing up or if it's the longus coli and the more inner stuff, and at what pressure does that happen? And there's like a kind of a general standard range. And
Yeah.
if your SCM's like firing right off right away, well, that's an indication that we need to work on the longus coli or whatever. So would that be kind of generally what they do?
Well, he would be more testing, like for example, unilaterally is left versus right working better. Okay, then he would be playing along with that. Um, like for example, you can connect SEM with tibius anterior with your foot because there's also a long chain in there, and like sometimes many patients have trip their foot or something like that, and so their foot damages, and so they reactivate foot muscles to reactivate neck muscles. via long chains. It's like long anatomy chains. Yeah, look,
Ah,
Anita
makes
has this
sense.
one as well.
Yeah, the Passion
Oh,
book.
yeah.
A
Yeah.
great freaking, it's a great book, and so that's it's like to understand the chains. Um, but yeah, so I'm also playing with that now. I'm doing a bit of it myself with it because like I also find like a hyoid bone. It's a really important part of the anterior musculature of the neck, and so if the anterior if you have, for example, disactivation of the infrahyoid muscles, you can have like the side opposite active. You need to activate the side opposite, but that can be a tremendous thing when you consider stability to the neck once again. Like, you can reactivate left, right, like depending upon how it is. But how they would test it, they would pressure or they would swipe or they would pull up depending upon what kind of muscle it is. And then they would give a strong muscle and then only one would be weak. And then on that weak one, like, okay, this is a weak link. Now what's the connection? And like that, you need to understand the chains, how they are in the body to create the stability. But it's part of this. This is just a classic orthopedic test, but it's like taking that orthopedic test, shaking it around, and looking how it fits in a chain.
Awesome.
Yeah.
Well, those are all the questions I've got for you guys. I know it's evening for you now. And but is there anything else you guys want to touch on?
No, I think you had a question on do we do any other treatments? Yeah, I do love the vagal nerve treatments or the cell ganglions. I really like these. And initially, what I told people that at first the same thing. First, work on the stability, see how your sympathetic nervous system and your vagal nerve correct themselves, and see how that works out. And if not, we're going to do some resetting. So, which means we would work with local anesthetic, like turn off and make. Hopefully, it'll come back on. Um, and I think now Centeno is using a lot more of the platelet lysate during the procedure time to actually activate the vagal nerve. And that's something that we've been starting to do because if I would do it during the procedure, that was not working out very well. So I would turn it off, especially sympathetic nervous system, and then it would go on so hard during that inflammatory response. It was just really bad because they had like a good couple days, and then all of a sudden they had a huge flare up with a lot of anxiety and stuff like that. So I stopped doing the combination of both. But I think with the platelet lysate, I'm gonna start adding that to the procedures for people with a lot of these, autonomic dysregulations, panic attacks, bad sleep and stuff like that. So I'm definitely gonna add that. And I really love doing I do that for a lot of stress, sleep disorders, anything that sounds a little bit of a autonomic dysfunction. I will go like, let's just go for it. And I'll do vagus nerve and stellate ganglion at the same time. I'll do C4. I mean, it's really hard to do just vagal nerve. You're always gonna have a touch of the stellate ganglion at the same time. It's just gonna go underneath that carotid sheet. It is what it is. And sometimes it's even in the same sheet, right? So you cannot avoid. You'll have both. You'll always have like you see the face with the horner and everything like that. That's very typical. But I love them. People are. I had someone 2 days ago. She napped in the recovery for 2 hours. I'm like, is she still here? Like she's sleeping. So it was just I'm like, okay, should we like wake her up because we're almost done here? But she looks so peaceful. So that's something that I really enjoy doing. It's very gives you a lot of it's very rewarding, yes, and it's a fun procedure to do as well. It's very ultrasound guided. You can see all these details, and it's a lot. I let people watch and explain them everything and what they can see. So that's something I think it's a very cool thing to do. And that's something we already trained to do in classic anesthesia, but we don't use it for these indications. But that's something that I think a lot of my colleagues could easily add into their programs and have done. And yeah, it's a great procedure.
Yeah, and that's getting more mainstream or widespread, I guess, is that, for some people, if you have CCI and you just fix up the ligaments, everything else falls in lines and in line and you're good to go. Other people, it's like, well, there's a little bit of damage that's been done and we have to intervene. We've already fixed the ligaments. We could see that on imaging or whatever, but there's a couple other things we've got to take care of. So yeah, I think that's a good idea. I've had it done myself.
Good.
Cool.
With local anesthetic or with the platelet lysate?
I think platelet lysate. Actually, I had occipital. I think I had occipital hydrodissections, and I don't remember if I did the stellate ganglion or not. It was during my one of my procedures, so I don't recall. Yeah. Um,
Yeah, I mentioned.
cool. All right. Well, Relief Clinic in are you guys in Brussels?
Yeah, close to Brussels. I mean, we're from so Belgium is tiny, but we're still, like what, an hour and a half drive separate from each other because you have to go around Brussels and they're always working. There's a lot of traffic, but yeah, I'm on one side of Brussels and he's on the other side of Brussels. So yeah, I'm close to the airport. That's true.
Okay.
Close to
Nice. Is there a
We're
train stop
looking to
near you
have
guys?
a chopper connection.
Yeah, exactly. We should have something that like that. Yeah. So you wanted to, I don't know if you wanted I walked around the clinic. I don't know if you if that's important, if you wanted to catch a little bit of a vibe. It's very like low key. Eventually we'll have a big clinic together, right? That's what we're talking about the entire time. We'll have this big thing. And for now, we have this, I have my daughter create to do that, do the little video. Like I said, it's still a very small clinic. What I think is important that people feel very at ease. You can see my coffee machine is right there. It's very important that everybody's.
Is it playing?
I'm gonna play that. There it goes.
A cute little office.
Yes, it is a cute little office. It is what it is. We'll get bigger at some point. Coffee machine, like I said.
Hey, there you go.
So this is our
Nice.
infrared sauna coming up. We're trying
Oh,
out for the moment.
For pre-injections, right?
Pre,
To heat.
post. Yeah,
Yeah.
I love the infrared sauna.
I do too. So this is a
Mhm.
biosafety cabinet requirement from regioning. Screen so people can watch while I'm doing the procedures. So we have do two centrifuges, double spin procedure, consultation room, in
Nice.
debug,
That's
radio frequency.
Do you guys do like IV drips or something with that?
Yes, yeah, sure, absolutely. So we do I do everything, everything. All right. So that's it.
Very
Sorry, I'm
cool.
gonna block it now. Yeah. All right. Yeah, we do a lot
Awesome.
of things. So I'm integrative doctor as well. So we do a lot of blood analysis and I mean we're working with regenerative therapy. So I tell my patients we're using your product, we're injecting it into your body. We want to have a great response, we have a great outcome. Everything needs to be on the right track. So if you have systemic inflammation, and that can be due to stress, and that can be due to pain and everything, like I understand completely. But if you're hurting all over and I don't know, your CRP is constantly over 10, we need to be looking at what's going on and maybe optimize first before we start, doing these treatments. It's no use spending a large amount of money on me and not having the maximum outcome. So I even blackmail people with my procedures. I'll tell them you first need to go see my nutritionist and get in better shape, and then we'll do these injections for you. Yeah, so I think it's very important, and we'll use whatever we need. We'll do IV drips. We'll put them in saunas, whatever. Yeah, so I think it's very important to look at it as a total patient. We'll do some vagus nerve injections and let them sleep for hours. I mean, whatever it takes to get them through it. uh, yeah, because I want to, and even like hormonal therapy. I will talk to women and go like, so, what's up with the bad sleep and the hot flashes and yeah, whatever it takes to get them through this. We'll do that. Yeah.
Very cool. And Geoffroy, what your clinic name again?
my clinic name is at the moment still chiropractor Van Innis, but I want to change it. Just because I'm also looking to maybe hire another associate. Just because like we're expanding a little bit the office. We're doing like also laser therapy pretty soon, like another techniques. So like we want to get a bit more global. I also work together with nutritionists, which is really fun. Like like I really realized like in the last couple of years, like I've been growing more and more in the sense of like I want to really help people like laterally, like like not just keep them for myself, but like I can't fix it myself. Like I really need other people, and Anita has that mentality even more than me. She's insanely good at finding the good connections for the patient in need, and that's super important because you can't heal somebody when the body's not ready to heal or to take an adjustment. So at the moment, to answer your question, the name is still called Chiropractor Van Innis. And they will be able to find me here. I'm still in my office here. It's I have a really nice office as well. Like it's very luminous and lots of nice windows. Uh, but I didn't prepare a little video. Uh,
Well, if you want to take some pictures and send it to me, I'll add it to the video.
well, wait, where's my? Here's my mobile phone. I know because I know on
I mean,
Thingy
you can
I
send
can
it to me
send them.
after. Yeah, yeah,
Usually,
I'll add it
usually,
to it.
usually you can walk it through. Like I do lots of video calls, and then I walk them through my office. But I'll send you a couple of pictures. It doesn't matter. People who want to see me, they won't come just from my office. But when they're in my office, they also feeling very at home.
Do you have coffee? Do you have a coffee machine?
I do not offer
Oh,
coffee
you
because,
Oh, you're
don't,
European.
Geoffroy.
Come on.
What is wrong
well,
with you?
it plays with the thermography people. Like
I had a patient coming in saying, when I come into your office, I don't smell the disinfectant. I smell the coffee.
coffee. Classic doctor
That's better.
office.
That's relieving as a patient. I'd rather smell
Right?
coffee than
Right,
Lysol.
exactly. That's what I want to do.
Yeah.
When I have it doesn't matter if I have a big the clinic gets, I want to have that like that coffee that area when you come in and you just get sit down and have a like a good coffee and then we'll go from there.
Yeah.
I need to buy a
First
coffee
settle
machine.
down and then we'll start with the with the consultation or treatment, whatever. Yeah.
I really need to buy a coffee machine now, I think.
You do. I'll buy you one for your birthday.
Yeah. Cool. All right, guys. Well, thanks so
Thank you
much for
so
your
much.
time. Yeah,
Thank
Thank
you.
appreciate it.
Nice
Like it's
meeting
You,
also
you.
not a time for you, and it's also not easy as a patient of doing these things. But I think what you're doing is really great for literally like the searching patients because like it's such a hard search to get to people like me and Dr. Van Domselaar. Like it's really hard. So I thank you so much for your time as well and for the effort you put in for the other persons. It's not an easy thing.
yeah, I just remember laying in bed in a dark room for so long, in and out of the hospital, having every scan, and every doctor's just shrugging their shoulders, and I'm just like, I remember thinking like I can't even find anybody who's gotten better. It's only people suffering, and it's just confusing. And I don't know which rope to grab onto. I don't know what's going on. And I was like, if I ever get through this, I am going to help as many people as I possibly can, and that's the mission. And yeah, so you guys are a part of that now too. So it's great.
That's
I think
nice.
you're on
Thank you.
track.
Yeah, cool. All right,
Keep up
guys.
the
Well, I'll send you
mission.
the video when it's all done.